All right, ladies and gentlemen, we're going to move to our next panel. I'm Willarda Edwards, and I am past president of the National Medical Association and also a Maryland delegate to the AMA. I have really enjoyed what we've been talking about today. Always appreciate the opportunity to be here. When Dr. Puckering said, could you moderate this program, I said, oh, of course, I'll be there. I would love to do that. I've also, as a private practicing internist in Baltimore, just started this year what I call a fitness clinic in my office. We have some 3,000 patients that we have in the last 2 years put into our electronic medical records. And when I pulled up what people's BMI, what their BMI was, but if it was higher than 27, I had 883 people out of my 3,000 patient records that had a BMI over 27. And so I said, this is important for my partner and I, it's just two physician internists, said we need to make sure our patients are more focused on what they need to do in terms of improving their fitness status. And so because of what I heard earlier today, I'd like to see some of us put some of what we heard today in action. Please stand for me. We want to make sure that we get a little kinetic learning here, do a little activity burst. Let's do what the kids did. Just move those feet up and down, just move your feet up and down. Let's start with that. And then I want you to reach up, bend down, reach up again, and touch your toes. You are focused now. That's good. All right. All right. Thank you very much, and I appreciate our speakers helping me with that. So we have before us today Drs. Gavin and Dr. Thorpe. Dr. James Gavin is a clinical professor of medicine at Emory University School of Medicine in Atlanta, Georgia, and clinical professor of medicine at Indiana University School of Medicine in Indianapolis. He serves as the CEO and Chief Medical Officer of Healing Our Village, Inc., and he's also a past president of the American Diabetes Association and was voted Clinician of the Year in Diabetes by the ADA in '91. Dr. Gavin's presentation will be on obesity as the new public enemy of American health. We are, or are we, up for this fight. Then he will be followed by Dr. Kenneth Thorpe, who is the Robert W. Woodworth Professor and Chair, Department of Health Policy and Management at Rollins School of Public Health. He was Deputy Assistant Secretary for Health Policy in the U.S. Department of Health and Human Services from '93 to '95, and in this capacity, he coordinated all the financial estimates and program impacts of the President Clinton's White House healthcare reform proposals. He will be discussing the effective approaches for managing obesity and chronic disease. And now that we have you in a learning focus, I'll have Dr. Gavin come forward.
Thank you very much, Dr. Edwards, and I'm glad to know that everybody's kinetic learning activity is now fully stimulated. So I'm going to talk about obesity as a new public enemy of American health. And I want to begin by looking first at why we are concerned about obesity. It has really little to do with the cosmetic issues around obesity. It really has to do with the fact that virtually no system in terms of our health is untouched with respect to risks for adverse outcomes. No system escapes the ravages of obesity. And I want to point out that in the footnote that cardiovascular disease is very common in obesity due to the accompanying metabolic syndrome. And it's because of this amalgamation of risk factors for cardiovascular disease that occurs so commonly in the setting of obesity that it contributes so significantly to cardiovascular disease. So when we look at the sheer scope of obesity, it's really enormous. About 111 million adults in this country are overweight or obese with a weight-related comorbidity. A large number of people, as you see, have obesity, but when you start looking at how that parses, there are millions of people who have obesity plus. They have obesity plus up to 3 additional comorbidities, each of which carries the burden of increasing a person's risk for cardiovascular outcomes. So obesity-related illness and complications are expected to cost the healthcare system in excess of $500 billion per annum in the not-too-distant future. So where does it stand? When we start looking at obesity as a major public health problem, you look at these data, looking at the number of deaths due to avoidable causes, quite frankly. You note that at the far right, smoking has been for years the champion. And of course, we declared war on tobacco and on smoking. But look at what was closely tracking smoking as an avoidable cause of death in this country. It was obesity. It is obesity. And it raises the specter that obesity may, in fact, be the new face of public enemy to health of the American people. Now, a lot of people think that given the success or relative success that we've enjoyed in the war that we declared, the fight that we've been engaged in with tobacco, that maybe we can just simply extract from lessons learned in that fight and carry it over to obesity. I don't have the benefit of the time to go through each and every one of these elements here, but I want you to note that there are a lot of issues that were involved in the tobacco fight that we don't have in the obesity fight. For example, the issue of a definition. There was never anybody that pretended that there was a health benefit to smoking. Everybody's got to eat. So there are some analogies here that we have to really be careful about. And then with respect to whether or not we've had litigation, whether or not we've had the proof that industry has colluded to obfuscate the health impact, we just don't have many of those same kinds of analogies in the obesity war. And when we look at the data more closely, what we see is that in a way that is quite surprising, really, obesity decreases life expectancy regardless of whether you smoke or not. So whether you're looking at men or whether you're looking at women, this is female data. What you see here in blue, for those people who are at BMIs greater than 30, the life expectancy is lower in those who are obese, whether they are smokers or not. Obesity itself carries a significant burden of risk for shortening lifespan. And so here we have it. The trends are exchanging places. As we have seen progress in the diminution of tobacco use and cigarette smoking and its potential health impact, we are now seeing an uptick in the prevalence of obesity and its health impact in this country. And we're beginning to be, in some ways, pariahized. We are pariahs in the eyes of the world, even though this is a global problem. There are many people think that there's something unique about the overweight and obesity problem in America. In fact, the Italians are still upset with us because they let David go on a tour, and when it came back, it was it bore the scars of being in America for too long. So this is a problem for us. Because among the things that happened to us, and I'm glad that Dr. Edwards started our session off in the right way, we have a problem with sedentary lifestyles. And this is something that we really have to guard against because this is the profile of obesity. And much of what we've heard in this conference points out that we've got to get moving, and we've got to start moving early in order to avoid some of these consequences. Now, I'm pressing on this thing as hard as I can. Okay, so you've heard war analogies, and you've heard warfare talk from Gary and from others. And the fact of the matter is we have to think about staging the fight, declaring war if we're serious about making headway against some of these major threats to the health of the American people. Now, this obviously represents the ugliest dimension of war, the plume from a nuclear explosion. But it simply points out that sometimes the enemy is so dangerous and powerful that even with all of its ugliness, we have to declare war in order to prevent even greater costs from the disaster that looms in front of us. And I simply want to point out that working in association with the First Lady's Let's Move program, an organization that I chair, the Partnership for a Healthier America, is working very actively to prevent childhood obesity and to get kids moving and to get kids eating healthier in order to nip this problem in the bud at its roots. And this is one of our war room scenarios. We're in the West Wing of the White House in a strategy meeting. I think you recognize the elegant gentleman in the foreground, but the other members of our board and the First Lady, we are deeply enmeshed in some serious strategizing here. Because this is where the problem begins. There's not a single adult problem that doesn't have its beginnings somewhere in childhood or adolescence. This is a significantly worrisome picture. It's daylight if you look at the window, and this kid is sitting there in front of a TV with a huge bag of whatever that is and a huge bottle of something else, watching God knows what. Almost 60% of overweight children have one or more cardiovascular risk factors. 40 to 50% of severely obese children actually have metabolic syndrome with all of its attendant risks on bad cardiovascular outcomes. And when you look at how this breaks down, what we see is that the prevalence of elevated cardiovascular disease risk factors among 3 to 6 year olds with a BMI greater than the 95th percentile for their age and sex. And you can see that this line up here, the third line from the top, is the 40% figure. 40% of our kids, look in the red color, these are Latino children, okay? And you can see that this is a significant problem as you look at all of these different risk factors, whether you're talking about high sensitivity CRP, total cholesterol, low HDL, high blood pressure, and so forth. These are significant numbers, and they become even more problematic when you consider what's going to be happening with our population in the not too distant future. The highest risks among those children are represented in the children who are in the fastest growing segment of our population, in the Latino population, followed very closely thereupon by the African American population. So what is it? Is it gluttony or is it sloth? Which of the 7 deadly sins must we target our focus on? Well, clearly we have to do both. We have to get moving, and we have to change the paradigm of nutrition in this country, and to do it early, because we know what some of the consequences are. It's really intra-abdominal or visceral fat that constitutes the greatest danger. And this represents a very familiar CT scan, a slice that shows that all of that white stuff in there represents fat that's bathing the viscera. And this is fat that is associated with some very, very bad consequences. It increases cardiovascular risks. And what you see here is that if you look simply at some of the most sensitive markers of insulin sensitivity, insulin and glucose levels, that those people who have the highest levels of visceral fat are the people who are most likely to have not only higher levels of insulin, but also at the same time high levels of glucose. Well, the only time you have that combination is when you are significantly insulin resistant. And there is no setting where insulin resistance is a good thing for you. And so these are the people who carry the burden of increased risk for coronary heart disease. Now, coronary heart disease is the leading cause of death in obesity-related disorders. And we ask ourselves, how does obesity contribute to end results that look like this? Obviously, the fact that you're seeing a picture of this ruptured thrombus or atheromata is a bad thing, because it means that it was on somebody's pathology specimen. Well, it turns out that there are features of the metabolic syndrome that are found in viscerally obese patients that, in a nutshell, really what captures it is that all of the risk factors that we are most worried about are found in metabolic syndrome. Insulin resistance, low HDL, high levels of LDL, particularly the small, dense types of particles, a hyperinflammatory, prothrombotic state, and usually hypertension. What is it that makes obesity such an important contributor? Well, fat itself, particularly visceral fat, drives much of what we know to be the high-risk metabolic syndrome. And this is the way it plays out. As we get larger, particularly centrally, older, as we smoke, as we are inactive, all of these things contribute to the interaction of risk factors that contribute to increased vascular damage. Okay? And then you couple genetic factors, which we don't have time to even touch upon, with that, then you see why it is that obesity, particularly in a sedentary environment, constitutes such a high-risk state. And these risk factors interact, okay? And this now puts our attention on adults in the 55 to 64-year-old bracket. Whether men or women, what we've seen is that there is an increase in the prevalence of these risk factors now with time. As we've seen the time go by, we become more sedentary. We become more obese. And that's led to more of our risk factors piling on and interacting. I keep mashing this thing. Y'all need to replace this thing because my thumb is hurting from pressing this damn thing. And these risk factors are synergistic, okay? And what this tells you here is that when you increase blood pressure and you now add increased blood pressure to high total cholesterol, to smoking, to low HDLs, male sex, diabetes, and increased age, with each additional risk factor on top of each of these, you see the 5-year cardiovascular disease risk. That is the risk of having something bad happen to you, a stroke or a heart attack, progressively rises. So the question that I put to you is the same question that my daddy shed some light on with me years ago. He said to me when I was a kid, that the only way to really stay out of trouble, boy, is to avoid it. And I won't give you the context because I don't have time, okay? And of course, at that time, I had no response. You better not have a response because, you know, that would be met with dire consequences. I just said, yes, sir. We have seen obesity emerge as a true blue epidemic without any real definite treatment. And yet the data are very compelling that if you look at the effects of weight loss, whether it's 5% or 5 to 10%, you see that there is benefit on all of those major risk factors that we are concerned about in the setting of obesity and metabolic syndrome, okay? In fact, if you look at the guidelines that have emerged, the NIH guidelines for selecting a treatment for obesity in adults says clearly that lifestyle change, that is physical activity and better nutrition, is appropriate for everybody, no matter whether you are in the modestly overweight or obese category. Those people that need pharmacotherapy are those people who have even moderate obesity or overweight in the presence of comorbidities. And then, of course, the issue of surgery begins to be a problem with different levels. This is where we have been in a conundrum, because we've had, on the one extreme, we've had lifestyle as our toolkit. We have been trying to get people to exercise and eat better and to lose weight using conservative approaches. And then at the other extreme, we've had gastric surgeries. Okay? A rather drastic solution to a public health problem, if you ask me. What's been missing is this middle ground. We have had very little to offer people in the way of effective pharmacotherapy. Back, please. And yet there's clear evidence. This is information taken from data with one of the newer incretin-based therapies, and it simply shows that as an intervention, this particular drug was able to achieve some degree of weight loss in a sustainable way. And not only that, but you can see down here that these metrics that were changed in a beneficial direction, this is a diabetes drug, but the metrics that are assessed here are all cardiovascular risk markers. And what you see is that they all improved. Weight loss does in fact occur with certain drugs, and we're seeing the emergence of additional treatments that are capable of causing this particular outcome. And it has in some ways presented us with opportunities on the one hand, but on the other hand, it's caused us to have a bit more confusion in the options that are available to us. Who needs what? And it's costly. We start screaming about the fact that it costs money to do this. Well, the fact of the matter is that the conduct of war requires the right tools. It requires complex logistics and coordination, often messy and costly. That's what we are engaged in this fight against obesity. No different than the Berlin airlift in post-World War II. Now you're skipping over stuff, okay? Okay, so what has been recommended? Well, these are CDC strategies that have been recommended to help us in this fight. And they include strategies to promote the availability of affordable, healthy food and beverages, strategies to support healthy food and beverage choices, to encourage breastfeeding, strategies to encourage physical activity or limit sedentary activity among our children and youth especially, strategies to create safe communities to support physical activity, and a strategy to encourage communities to organize for change. Complex logistics, sometimes costly, sometimes messy. So we go back to that question that my daddy asked me. You know, the fact is, if I had been quicker on my feet, I'd have said to him, when he said, boy, the only way to stay out of trouble is to avoid it, I'd have said, well, Pops, the trouble might come up so fast and present such danger that what we might have to do is to immediately gear up for the fight. If I had been really quick and clever, I might have been able to say that. But the fact that I'm alive today suggests that I didn't and I wasn't, okay? Okay. So let me just say, why do we then focus on this treatment of obesity as the first line of attack in the treatment of obesity-related disorders? Because it's clearly associated with increased morbidity and mortality. And there is evidence that if we can gain some traction with weight loss, we can actually reduce those risk factors that drive bad metabolic and cardiovascular outcomes like diabetes and cardiovascular disease. Now, there are currently no prospective trials to show changes in mortality with weight loss and obesity. In fact, the Look Ahead trial was somewhat disappointing in that respect. But, you know, the fact of the matter is, if we are not careful, if we don't do something differently, this is from the Highway of Doom. This is a picture from the Persian Gulf War in 1991, where a large convoy of Iraqis were trying to get back to Baghdad at the wrong time and in the wrong way. They were trying to get there in a huge convoy, which lent itself to some bad bombing and strafing. And this is the kind of doom that happens when you organize for the fight wrong. So the question is, are we up for this fight with obesity and overweight? Well, I don't know whether we are or not. We certainly have a lot of moving parts that are in place. And I know that our attitude is one that says, you know what? We know what the problem is. We know what we got to do. And by golly, we are never, ever going to give up. Thank you all very much.
Boy, that's going to be a tough act. Now, the corollary to the staying out of trouble, boy, that brought back a lot of memories.
I'm telling you.
My mom told me, Ken, nothing ever good happens after midnight. So and I got to remember that to this day. It's a pleasure to be here. I thank the forum for inviting me. And it's a pleasure to share the stage with these two very well-respected physicians as well. Well, we'll see if we can get this to work. There we go. I'm going to come at this at a little bit of a different angle, very much the same types of message in terms of obesity, but looking at the impact that it has economically, and also to try to provide some ways that we could probably attack these issues of obesity, both in terms of prevention and management. So I think this, even though we didn't coordinate these, I think it's a nice combination of how we're approaching this. You've seen the data in terms of the share of adults considered obese. It's 36% today. It's doubled since the mid-1980s. That doubling of obesity in and of itself accounts for about 10% of the growth in healthcare spending. It's one of the biggest predictors and most powerful forces driving up healthcare expenditures in this country. We don't have, as we've talked about, effective comprehensive prevention programs on reducing the prevalence of obesity. And we really don't have a healthcare delivery system that's very effective in engaging patients that are obese and that have multiple chronic conditions to keep them healthier, to keep them out of the hospital, and so on. And a third issue is that we still have low rates of detecting disease. We only are detecting about 72% of total diabetes in this country. A lot of opportunities. Again, in this town, as you well know, we can always make the healthcare case for battling obesity. It's the right thing to do. It'll improve mortality rates. It'll improve morbidity. But the bottom line, people here listen to money. Mm-hmm. And one of the things that I think has been important is link the case for the rise in chronic disease and obesity to our healthcare expenditure problems. So just for example, Medicare, since we really don't have a system of care coordination in traditional Medicare, over the next decade, we're going to spend about $500 billion more on healthcare spending just because patients are readmitted to the hospital. Medicaid has the same sets of issues as well. Oh, see, this isn't so hard. This is the same chart, just coming up more recently. The red line being the obesity rates, the other line being smoking rates. The good and bad news in this, we have improved and reduced cardiovascular mortality in this country very substantially over the last couple of decades, in part due to more effective use of hypertensive drugs, statins, and also reducing the smoking rate. But we're really offsetting a lot of those gains by the rise in obesity. So that's really a major public health challenge. If you look at some of the issues on disease prevalence, these are a subset of conditions linked to obesity. And if you look at just since 1987, the share of adults being treated for some obesity-related conditions has increased dramatically. So this is sort of the economic avenue by which the healthcare expenditures are rising. So we know the prevalence of chronic disease is very closely linked to rising rates of obesity. We've already talked about the link between obesity and diabetes, but I think this chart is really sort of an interesting way of looking at it. So this is the prevalence of diabetes. These are incidence rates, and this is obesity. I mean, they're basically the same line charts over time. And so Virtually all of the increase in diabetes that we see in this country is traced back to a change in the distribution of body mass. Say that again. Almost all of the increase in diabetes that we have is linked to these trends in terms of rising rates of obesity. In the Medicare population, which I'll make the case in a minute, 27% of seniors are diabetic. Another 50% are pre-diabetic. Those numbers have doubled over this time period. And I'll come back to that theme in a second about the discussion about entitlement reform. That's really not part of the discussion about how to reform entitlements. The theme being is that we really need to do health reform if we're going to do healthcare system reform and entitlement reform. The costs are very substantial, not only in terms of the direct medical care costs, but in terms of productivity. Employers are losing about $4 billion a year due to higher rates of obesity. The medical care costs linked to obesity for an adult is about $2,700 a year higher. That's about 21% of total health care spending. It's about $200 billion, depending on the year that you want to look at it alone. So we've done some calculations that basically said, suppose that we could have magically froze the rate of obesity in this country at 1987 levels. That would have shaved about 10% off the cost of health insurance, about $2,700 per year. This is in the Medicare population, and this is what I think is sort of interesting over time. This is looking at the number of beneficiaries by the number of chronic health care conditions they're being treated for. And if you look at 1987, 31% of the population was being treated for 5 or more chronic conditions. Today, over 50% of seniors are being treated for 5 or more chronic health care conditions. So that's that big group, green slice there. So just remember that. Today, about 53% being treated for 5 or more chronic conditions. In Medicare, that's 78% of spending. That's where all the money is. All of the money in Medicare is linked to chronically ill patients, much of which goes back to underlying growth in levels of obesity. In fact, in Medicare, 95% of total spending is linked to patients with 1 or more chronic conditions. And 78% of it is due to patients that have multiple chronic conditions. If you look again at what this translates over time into per person spending increase, this is inflation adjusted. For normal weight patients, the annual increase in inflation-adjusted per capita spending, about 2.4%. Among obese patients, is 3.8%. So to the extent you can sort of see this leveraging, if we have more and more people moving from the normal weight and overweight category into the obese category, it has a direct impact on one of the key drivers of rising healthcare expenditures. So when I think of health reform, I think about health reform in these 3 dimensions. And if we talk about reforming healthcare, yes, we needed to do insurance expansions, and we needed to have a financial engine to pay for things. That's very important. But when I think more comprehensively about healthcare reform, I think about these 3 issues. We need a more comprehensive national approach that does a better job of averting the increase in chronic disease prevalence and incidence. Secondly, a system that does a better job of detecting disease earlier on. And third, a system that does a better job of more effectively working with and managing chronically ill patients to keep them healthy. So if you just go back to the notion that in traditional fee-for-service Medicare, that has no comprehensive care coordination program at all, despite the fact that you've got nearly 77% of seniors that are pre-diabetic or diabetic, and virtually all the spending is linked to people with multiple chronic health care conditions. It would seem to me that if we're thinking about entitlement reform, that's an area that's really ripe for having a more thoughtful discussion. What do we know about approaches that do a good job of averting disease in the first place? And the good news is that we do have programs that we have years of randomized controlled trials on that have been shown that if you target overweight, pre-diabetic adults, that we can reduce the incidence of diabetes within a year by 58%. It's called the Diabetes Prevention Program. How many people have heard of the Diabetes Prevention Program? 10 years of follow-up data on this. They show a cumulative reduction in the incidence of diabetes of 34% over 10 years, even with some weight gain during that time period. Wow. What's more impressive, I think, for the entitlement reform discussion is that this thing affects everybody across all ages, races, socioeconomic status. Among seniors, 60 and above, the program reduced the incidence of diabetes by 71%. We have 50% of seniors that are pre-diabetic. We have a program that if we could engage people, actually have it available, that has the potential of reducing the incidence of diabetes by 71%. That's an amazing statistic to me. That's something that, in terms of public policy issue number one, I would like to find a way to build this program like a program like this out, have it available nationally, so that physicians can refer patients to programs that they know work like this. Well, what does Medicare currently cover for obesity? Well, you know, there's really those three avenues that were talked about: lifestyle intervention, pharmacotherapy, bariatric surgery. Well, Medicare covers bariatric surgery. It does not cover weight loss drugs. There are at least 2 new classes of weight loss drugs that are FDA approved that have come out within the last year, showing very promising results of about 10 to 15% weight loss. We do have a program like the Diabetes Prevention Program that generates about an average of 7% weight loss within the first year. That program's not covered. Medicare does cover some intensive behavioral therapy provided by physicians, but it's a very limited benefit. And it's really not, to me, the right benefit design if we're going to make a difference here. So of those 3 channels, Medicare just covers 1. The private sector is moving very quickly into, I think, offering all 3 of these services as part of their benefit design. So if we're talking about entitlement reform, and I'm using, again, Medicare as a way to kind of leverage change in the system, because a lot of the change in broader healthcare reform does flow through the Medicare program, since it's such an influential payer and it's such an important part of our healthcare delivery system. One is that I think that we should look seriously at building out and adding programs that are evidence-based, like the Diabetes Prevention Program, as a covered benefit in Medicare. So if you think about Medicare today, it has a physical that you get a risk assessment, you get a personalized care plan that says, you know what, you're overweight, pre-diabetic, you probably should lose weight. But it doesn't cover anything that actually allows you to act on that. Well, we need to square the circle and make something like the Diabetes Prevention Program or other similar programs available as a covered benefit. They should look seriously at adding these new classes of FDA-approved weight loss drugs used in conjunction with lifestyle change. They're more effective in combination. I'm not going to go through these results for the DPP. You can look them up. But just to give you a sense of the impact of weight loss and incidence of diabetes, is that every kilogram of weight loss that is generated has a 16% reduction in the chance of getting diabetes. Just to put it in perspective, if you look at a 50-year-old pre-diabetic adult, their lifetime chance of getting diabetes is 87%. Pretty high. If you enrolled that 50-year-old pre-diabetic overweight adult into a program like the Diabetes Prevention Program, it goes down to 62%. It's an enormous reduction in incidence and prevalence of diabetes. It's sort of misnamed here, called the Diabetes Prevention Program. I really think of it as the Chronic Disease Prevention Program, because it has a much broader set of impacts on chronic disease besides diabetes. It affects hypertension, hyperlipidemia, back problems, asthma, and so on. And if you think of the clinical challenge that we face in programs like Medicare, as you've already seen from the data, the typical profile of the patients driving all the expenditures in the program is an overweight, hypertensive diabetic that has bad cholesterol, asthma, back problems, pulmonary disease, and is depressed. That's our patient. Seeing multiple physicians, multiple medications, none of it's really overall coordinated in any coherent way. What about managing chronic disease? That's, to me, sort of as I think about entitlement reform, if you think about it in terms of the money in Medicare, nearly 80% of the spend linked to patients with 5 or more chronic conditions, we really need a comprehensive team-based approach to deal with that patient, because those patients have everything from acute care problems to cardiovascular problems to mental health problems, behavioral problems. So you really do need a team of healthcare providers, not just physicians, but teams that include nurses, nurse practitioners, pharmacists, social and mental health workers that are working with patients to help them be engaged and make sure that whatever care plan is in place is actually followed. So the good news is that we do have an abundant amount of evidence that shows that if you design care coordination effectively, it works. It's all in sort of what are the components that you build into it. Transitional care, meaning working with patients post-discharge from a hospital or nursing home and doing some of the health coaching. Well, we've got two models that we've seen for over a decade, very comprehensive models that would cut readmission rates to the hospital in half. Medicare has just added a code, a new CPT-4 code, to allow physicians to bill for it. I'm not sure if physicians are the right ones to do the transitional care, but at least it's a start in the right direction. Comprehensive medication management. If you think about these chronically ill patients, what you need is good primary care and effective medication therapy, because most of these conditions we're talking about really are managed by different types of medications. Medicare has a very limited benefit. Only 10% of seniors in the program use any type of medication therapy. We could do a lot better job in terms of thinking more broadly about whom to apply effective medication therapy management to. What about just health coaching, working with patients and their families to make sure that they understand the care plan, understand how to negotiate and navigate the system? Did they even understand what the physician said in terms of their care? Did they understand that? If you think about it, a patient might see a physician 2, 3, 4 times a year. The real challenge in keeping them healthy and out of the hospital is what happens the other 360 days a year. Mm-hmm. Who's there working with these patients when you're not physically in a physician's office? Well, that's where part of this team-based health coaching comes into. And I think having these links to allow people to be referred to evidence-based lifestyle programs is an important part of the puzzle as well. Well, how do we do this? And I'm just stop with 3 or 4 ideas about how we could actually transform our delivery system that builds in better prevention, better disease detection, and better care coordination. Because we have the policy tools in place to do that. One is that in the health insurance exchanges that are getting up and running right now, one of the components that's been, I think, largely ignored in the definition of essential health benefits is prevention and care coordination. Those are included as an essential health benefit. Well, for health plans that are offering services through the exchange, what are we expecting them to do in terms of prevention benefits and care coordination? Should we expect them to use some of these evidence-based models? Can we use sort of some leverage here to transform the delivery system a little bit more quickly using the exchanges? In the Affordable Care Act, there's Section 2703 that allows state Medicaid programs that if they use team-based care to manage chronically ill patients, they get an enhanced federal match. Several states have gone down that direction. I'd love to see more states do it. We should include, as I've already mentioned, programs like the DPP and the traditional Medicare program. And we need to find ways to build care coordination into what we do into Medicare. We have care coordination in Medicare Advantage programs, but most people are in traditional fee-for-service Medicare where there really isn't any. So I think that the end of the day, if we think about the links between obesity, chronic disease, and spending, we really do have an opportunity, if we're serious about controlling healthcare costs, to really do healthcare reform. And if we really focus on linking and building out these evidence-based programs into Medicare, the health insurance exchanges, we really could transform the way that we prevent disease, detect disease, and manage patients with chronic conditions. So with that, I'll stop, and I look forward to your questions. Thanks for inviting me.
Great job. Thanks.
Sure. First question.
It's not a question, it's a commentary, but probably also has implicit a question. My commentary is very biased. I'm an ophthalmologist, and I have been in this meeting since the morning. I have heard only one time the mention of ophthalmology. It was at the bottom of the line, referred by somebody. 10% across the board, more or less, 8 to 10% of the diabetics are blind, and the diabetics can be depressed, and there is no more reason or no stronger reason to be depressed than being blind. And the spectrum of blindness is very serious in the patients. On the other hand, I have witnessed the change in the mood and in the attitude of the patients when they can be given eyesight again. They change their way they dress, they come clean, they can comb, they change the colors of the dresses, they are a different person. And I think that we need to include in all the list not only cardiovascular diseases, but blindness, because it's a very significant morbidity. Not only that, the diabetic patient needs to be seen by an ophthalmologist more than once or twice a year, because now we can make the diagnosis at a cellular level. And we can treat and diagnose the condition, macular edema, that produces blindness in diabetics when we can see the cells swelling. And sometimes even the patient is not aware of change in vision. But we can already treat that.
Thank you. Thank you for that comment. We'll try to make sure we keep that included in any of our discussions on chronic disease. I take it you're an ophthalmologist, right? Perfect. Yes, ma'am.
Dr. Edwards, Thorpe, and Gavin, I thank all of you for bringing together and talking about weight management in the adult population specifically. I'm Fatima Cody Stanford, an obesity medicine nutrition specialist at Massachusetts General Hospital and Harvard Medical School. I also have to thank Dr. Kenneth Thorpe, who was actually my teacher when I did my MPH several years ago. I haven't seen him since then, so thank you for introducing me and getting me involved in this spectrum of disease. One I guess, example that I wanted to bring forward with about the team-based approach and the success we've seen at Massachusetts General Hospital is our weight center, which we use a team-based approach and have since 1998 to see and treat patients, both pediatric and adult patients, that struggle with their weight. Each patient over the age of 12 is seen by a psychologist, a dietitian, and a physician, and we come together as a team at our team meetings, which are held on Thursday, to determine the treatment strategy which suits that patient, whether it be bariatric surgery, pharmacotherapy, management, or behavioral, or a combination of those. And so I think that approach has led to great success. Of course, we work in a model in the only state that really has universal coverage, so we don't have barriers that some states have. And coming from Atlanta and coming from Georgia, I know that a lot of the Southeast states specifically, along with many of the Midwest states, do struggle with getting appropriate coverage for populations that do need this type of help. So I want to thank all of you, but say that that team-based approach does work. I see it in practice every day, and thank you so much.
Appreciate that. Thank you very much for your comments. And with that, we will conclude, and really do appreciate Dr. Gavin and Dr. Thorpe giving us the presentation. And I'm also going to be on hand so you can tell you about my fitness clinic that has been successful in the adults that I see, and how I'm using that as Medicare does cover 14 stays, or 14 visits rather, in primary care practice when you're trying to focus on fitness in your patients. So thank you very much, everyone.